Case study, coronary artery disease by Ann Roberts, Tammy Pena, Carrie Mrazek, and Jessica Stennis. Brenda, a 68-year-old female, is admitted to acute care hospital due to chest and jaw pain. Cardiac catheterization shows severe two-vessel heart disease, and she undergoes CABG, coronary artery bypass grafting surgery. She now presents to inpatient rehab for 7 days before being discharged to home or other healthcare services. What is coronary artery disease? Coronary artery disease occurs when atherosclerotic plaque builds up in the wall of the arteries that supply the heart. This plaque is primarily made up of cholesterol. Plaque accumulation can be accelerated by smoking, high blood pressure, elevated cholesterol, and diabetes. Some of the risk factors include age 45 or older for men, age 55 or older for women, with a positive family history for early heart disease. It can also be accelerated by smoking, high blood pressure, high cholesterol, and diabetes. Coronary artery bypass graft (CABG) surgery reestablishes sufficient blood flow to deliver oxygen and nutrients to the heart muscle. The bypass graft for a CABG can be a vein from the leg or an inner chest wall artery.
Your doctor has recommended that you have coronary artery bypass surgery. But what does that actually mean? Your heart is located in the center of your chest. It is surrounded by your rib cage and protected by your breastbone. Your heart's job is to keep blood continually circulating throughout your body. The vessels that supply the body with oxygen-rich blood are called arteries. The vessels that return blood to the heart are called veins. Like any other muscle in the body, the heart depends on a steady supply of oxygen-rich blood. The arteries that carry this blood supply to the heart muscle are called coronary arteries. Sometimes these blood vessels can narrow or become blocked by deposits of fat, cholesterol, and other substances, collectively known as plaque. Over time, plaque deposits can narrow the vessels so much that normal blood flow is restricted. In some cases, the coronary artery becomes so narrow that the heart muscle itself is in danger. Coronary bypass surgery attempts to correct this serious problem. In order to restore normal blood flow, the surgeon removes a portion of the blood vessel from the patient's leg or chest, most probably the left internal mammary artery and the saphenous vein. Your doctor uses one or both of these vessels to bypass the old diseased coronary artery and to build a new pathway for blood to reach the heart muscle. These transplanted vessels are called grafts, and depending on your condition, your doctor may need to perform more than one coronary artery bypass graft. Of course, operating on the heart is a complex and delicate process. And in the case of bypass surgery, your doctor will most likely need to stop your heart before installing the graft. During the time that your heart is not beating, a special machine called a heart-lung machine will take over the job of circulating and oxygenating your blood. By using this machine, your doctor is able to repair the heart without interfering with the blood flow to the rest of the body. Following surgery, your heart will be restarted and you will be disconnected from the heart-lung machine. On the day of your operation, you will be asked to put on a surgical gown. You may receive a sedative by mouth, and an intravenous line may be put in. You will then be transferred to the operating table. In the operating room, the anesthesiologist will begin to administer anesthesia, most probably general anesthesia, by injection and inhalation mask. The surgeon will then apply an antiseptic solution to the skin and place a sterile drape around the operative site. One or more sections of blood vessel will be taken from the leg, thigh, or chest wall, and the incision at those points will be sutured and bandaged. Then your doctor will make a vertical incision in the center of the chest. Skin and other tissue will be pulled back in order to expose the breastbone. Your doctor will carefully divide the breastbone. And a special instrument called a retractor will be used to hold the chest open. Once your doctor has a clear view of the heart, he or she will make an incision in the pericardium, a thin membrane that encloses the heart. Pulling the pericardium back will reveal the beating heart. Before the graft vessel or vessels can be attached, a heart-lung machine must be connected. A heart-lung machine takes over the job of circulating and oxygenating the blood so that your doctor will be free to stop your heart for the length of the operation. To connect the heart-lung machine, one tube is placed into the aorta, and a second tube is placed into the right atrium of the heart. One or two smaller tubes are then inserted into the heart. These will carry a special solution that helps preserve the heart's temperature. When all the tubes are in place, the surgical team will turn on the bypass machine. It will begin to circulate the blood as the heart cools. As the cooled blood circulates through the heart muscle also cools, causing the heart to beat at a slower pace. When the temperature of the heart muscle has reached the proper level, a clamp is placed on the aorta. At that point, blood will no longer flow through the heart and it can be safely stopped and repaired. To complete the bypass graft procedure, your doctor attaches the ends of the new vessels on either side of the diseased area or areas of the old coronary artery. Once the grafts have been completed, the clamp on the aorta is removed, and the heart is allowed to begin beating again. As the temperature and the rhythm of the heart slowly return to normal, the heart-lung machine is disconnected. The pericardium can now be closed over the heart. Your doctor will position two special drainage tubes in the chest cavity. These tubes prevent fluid from building up around the heart during the healing process. The breastbone is then closed with metal wire. And the remaining tissue is closed with sutures. Finally, a sterile bandage is applied.
Risk and complications of CABG. It is an open heart surgery and one of the most common surgeries performed. The mortality rate is 3 to 4%, and some of the complications include bleeding or infection, irregular heartbeat, atrial fibrillation, memory problems, stroke, which is primarily related to age and a history of previous stroke, kidney failure, and a heart attack during or after the surgery. Brenda's occupational profile. She presents post-CABG. She is 68 years old and lives alone in a one-level apartment with 6 steps to enter. She has 4 adult children that live nearby, and her previous functional level consists of working in retail for 30 hours a week, independent and active, enjoys going out to eat, cooking, shopping, and playing cards with friends. She is currently neurologically intact, has a strength of 3 out of 5 in bilateral upper extremities, fair endurance, requires moderate assistance with ADLs due to fatigue, and requires minimal assistance for toilet and tub transfers. Brenda's past medical history include coronary artery disease, carotid endarterectomy, hypertension, hyperlipidemia, former smoker, and allergies to latex and iodine. Her current medications include Lasix, aspirin, KCL, Percocet, Plavix, Lipitor, amiodarone, Xanax, and metoprolol. Several of the medications Brenda is currently on can cause dizziness, lightheadedness, chest pain or confusion, shortness of breath, weakness, problems with vision, speech, walking, and joint pain. As we treat Brenda, we will monitor her for these symptoms and report them to her doctor if they occur. Brenda's sternal precautions after open heart surgery include avoid trauma to the graft site, incisions, and sternum for 8 weeks. The sternum is a healing bone that takes about 6 weeks to heal and must be treated as such. She has a maximum 10-pound lifting, pushing, or pulling restriction. She must refrain from driving for at least 4 weeks, avoid straining during bowel movement, wear compression hoses to prevent edema, prevent torque in the upper body, do not ride in a car without an airbag, and avoid rapid moving of the upper body. Treatment plan considerations and acute rehab following CABG. The OT and patient work together to create a plan addressing lifestyle and personal goals for rehabilitation. Activities and exercise begin initially at a low level. To maintain the correct level of functional activity, the therapist will estimate the metabolic equivalent rate required to do specific activities and will grade the activities up or down in estimated MET values to fit the patient's functional ability. Blood pressure, heart rate, and ECG responses are monitored throughout the treatment, and most self-care activities take between 1.5 and 3.5 METs. METs help establish parameters for functional activities. For clients with decreased endurance and low activity tolerance due to heart disease, the OT practitioners can use METs to determine the cardiovascular stress and work required for various activities. The goal is for the patient to perform activities at a level without dyspnea, palpitation, or angina during or after the activity. This is one facility's chart of metabolic equivalent levels of various activities up to 3 METs. Once the client are able to tolerate increased metabolic activities requiring greater than 3.5 METs with safe and appropriate heart rate, blood pressure, and ECG responses, they move to a maintenance phase of rehabilitation, which usually takes place at 2 to 3 months post-surgery and is comprised of outpatient OT services 2 to 3 times per week. To evaluate Brenda's occupational performance, we use various assessments including manual muscle testing, vital sign responses, Borg's rate of perceived exertion, Canadian Occupational Performance Measure, Functional Independence Measure, and Screening Range of Motion. The Borg Rating of Perceived Exertion, RPE, is a subjective measure of physical exertion using a rating scale from 6 to 20. Exertion and heart rate appear to be correlated. RPE takes 2 minutes to administer, and Brenda can also be taught to monitor her activity using the RPE scale. To evaluate and monitor Brenda's endurance, heart rate, blood pressure, and blood oxygen levels are assessed before and after each treatment session. The Canadian Occupational Performance Measure is an individualized, client-centered measure that detects change in a client's self-perception of occupational performance over time. It is designed to be used as an outcome measure. The COPM addresses clients' outcomes in the areas of self-care, productivity, and leisure. Brenda was administered the semi-structured interview during her first session to identify and measure her identified problem areas and daily function. The functional independent measure measures the level of disability in 5 primary categories, including 18 individual task areas. It takes 45 minutes to administer. The FIM is used to track changes in Brenda's functional ability while in inpatient rehabilitation. A range of motion screening was performed on Brenda during her first session to identify any deficits that needed further evaluation. Brenda has no range of motion deficits. Manual muscle testing measures muscle strength and identifies areas of weakness. Manual muscle testing of Brenda's upper extremities is performed upon initial evaluation and prior to discharge. Brenda's intervention plan will focus on the cause of the problems, consist of using different intervention approaches based on the biomechanical frames of reference, and target her occupational performance. Cause of problems relate to client factors involving body structures and body functions. Brenda's major body structure of concern is her sternum healing from surgery. Major body systems include the cardiovascular system and the musculoskeletal system with the factors of strength and endurance. The biomechanical frame of reference is used throughout the intervention program. Brenda is healing from an open heart surgery and will require a biomechanical approach that focuses on her physical condition. We are increasing strength and endurance, maintaining range of motion, and reducing pain and swelling. Intervention approach. Establish and restore for restoring Brenda to her previous level of function. Adapt and modify. Activities will be modified to maintain precautions during Brenda's healing process. Brenda's intervention plan will target occupational performance in ADLs and IADLs. Targeted occupational performance problem areas in ADLs. Brenda currently requires moderate assistance with dressing due to fatigue, requires minimal assistance with tub to toilet transfers due to safety, and requires moderate assistance with personal hygiene and grooming due to fatigue. These 3 problem areas will be identified using long and short-term goals. A long-term goal includes becoming independent in ADLs. Her short-term goals will be Brenda will don shirt and pants with minimal assistance within 3 sessions. Brenda will transfer to tub and toilet with standby assistance within 4 sessions. Brenda will brush her teeth and her hair with minimal assistance within 2 sessions. Short-term goal 1. Provide adaptive equipment and instruction to improve Brenda's dressing technique and energy conservation. This is a preparatory activity which will be given by the OT and the CODA. Brenda will practice donning button-up shirts to maintain sternal precautions of keeping shoulder flexion below 90 degrees until endurance increases or sternal precautions are modified by the physician. This is an occupation-based activity and will be given by the OT or the CODA in Brenda's room. Grading this activity up would be using a pullover shirt, and grading the activity down would be having the OT provide minimal assistance. Short-term goal 2. Educate and instruct Brenda on height adjustments of toilet and tub bench to promote energy conservation, maintain sternal precautions, and allow for easier sit-to-stand and increase safety. This is a preparatory activity given by the OT in Brenda's room. Grading this activity up would be having Brenda perform this transfer in a mock bathroom with a tub and shower combination. Grading it down would be performing it in her room with a walk-in shower. Reasoning for activities is based on the biomechanical frame of reference and knowledge of biomechanics of not wanting Brenda to push or lift her body weight. Targeted Occupational Performance Problem Area IADLs. Brenda is unable to prepare a meal due to lack of strength and endurance. Long-term goal. Return to cooking for self, utilizing energy conservation techniques. Short-term goals include Brenda will demonstrate understanding of energy conservation techniques during meal preparation. Brenda will perform upper extremity strengthening with yellow TheraBand, 2 sets of 10 repetitions, 1 time a day within 2 sessions. Brenda will prepare a light meal while using energy conservation techniques. Short-term goal 1. Brenda will be taught and practice diaphragmatic breathing, pursed lip breathing, dyspnea control postures, and relaxation of muscles. This is a preparatory activity given by the OT and CODA in Brenda's room. Diaphragmatic breathing involves using the diaphragm. This can be practiced by lying supine and placing a piece of paper on the chest while trying to make the paper rise when inhaling. For pursed lip breathing, an individual will want to purse lips as if to whistle. Slowly exhale and inhale deeply through the nose. Count inhaling for 2 and exhaling to 4. Dyspnea control postures can be performed by leaning forward slightly at the waist while seated or standing to reduce breathlessness. Muscle relaxation techniques involve systematically contracting and relaxing different muscles, inhaling while tensing and exhaling while relaxing. Brenda will practice sitting on a stool or elevated chair to stir food in a pot on the stove. Breathing techniques and breaks will be incorporated. This is a purposeful activity done under the supervision of a CODA in a mock kitchen facility. Reasoning is based on the biomechanical frame of reference, knowledge of the body function and breathing techniques to aid increased endurance, and maintaining range of motion through functional activity that is meaningful to Brenda. Short-term goal 2. Therapeutic strengthening upper extremity exercises in the gym 30 minutes a day to include TheraBand bicep curls, sitting in a chair, and upper extremity bike 5 to 10 minutes non-resistance to start in the OT gym. This is a preparatory activity under the supervision of an OT performed in the gym. Reasoning is based on the biomechanical frame of reference, and grading this activity up would be using higher resistances TheraBands or add resistance to upper extremity bike, increase sets or reps, or perform standing. Grading this activity down would be using less time, less reps, and no TheraBand. Short-term goal 3. Brenda will prepare a soup and sandwich meal in the kitchen utilizing sitting while preparing food, incorporating breathing techniques and breaks. This is an occupation-based activity under the supervision of an OT or CODA, performed in a mock kitchen facility. The reasoning is based on a biomechanical frame of reference, maintaining range of motion and building endurance through functional activity that is meaningful to Brenda. Grading this activity up would be having her perform it standing, reducing break number and length of breaks. Grading this activity down would be taking longer breaks and more frequent breaks. Service delivery. OT and CODA share treatment as outlined in each intervention activity. Co-treatment with physical therapy will also be included. PTs will work with Brenda on overall endurance and strength through gross motor activities. Frequency consists of 2 times a day for 45 minutes, 1 morning session and 1 afternoon session. ADL interventions will occur in the patient's room during the morning session. IADL interventions will occur in the gym and kitchen during the afternoon session. Discharge recommendations. Provide Brenda with breathing technique handouts and a home program of therapeutic exercises. Brenda will be receiving home health OT, and we will communicate with the home health OTR to update her on Brenda's progress and goals in the inpatient rehabilitation hospital program. Recommend continued OT intervention to ensure ongoing independence in ADLs and IADLs. Recommend further therapeutic exercises to target strengthening and range of motion. Brenda will need further energy conservation and work simplification training as her time to return to work approaches.